did that worksheet, and I showed you guys how the odontoid comes up into the C1. So yeah, this is basically the odontoid. And do we remember what the odontoid fracture was called? It was on the worksheet. Oh, pull out that worksheet because it's basically the same. You guys have that.
The hangman.
No.
So C, you said C2?
No, just the odontoid fracture.
Oh.
Where's your vocab sheet?
Yeah, get that vocab sheet out. Very
Oh, let
important.
me keep them so you.
Yeah, I have them.
Did you guys throw it away?
No.
It's right here.
The dog is mine.
Vocab sheet?
I have it.
You said fracture of the what?
Odontoid?
The seat too.
Dens.
Dense fracture, going to fracture. It's very simple. Very simple. So the odontoid fracture, it can also be called the dens as well. So it can be odontoid or dens, okay? And so we also, the most important parts you want to focus on when it comes to this, you just need to know the ligaments, the faucets. Faucets are just like the pockets that sit on top of each other, the spine. And then the arches, right? We have the posterior arch and the interior arch. So what is that thing called when you get a posterior and an interior arch fracture? Remember? In the C2?
Jefferson?
Jefferson. Remember how I said it? The serial killer?
Yeah, you
Right.
kids,
So what are the orientations again?
For what?
You said the Jefferson's fraction is posterior and
And interior fracture.
interior?
Yeah, the arches. So the
Okay.
posterior arch and the interior arch are both getting fractured.
They
And
both
then,
get fractured.
which one?
The posterior and the
Interior arch.
both of them get fractured.
Yeah, both of them get fractured. Yes, ma'am.
So is it like the pelvis in that way? Because like one force or one trauma caused that sort of fracture where it like travels through the circle or the ring? I don't remember what that was called.
I know when you say the pelvis, you
Yeah.
fracture one part of the
And then
pelvis,
it
it can
travels
travel to
to-
the other
mhm.
side.
Is
I'm
it
not quite
similar?
sure. Does that happen?
So, in this case, it's more like that the force is just affecting the entire vertebrae because usually with something like a hangman's fracture, right, you have basically kind of a pulling force that places stress on the entire ring of the vertebrae, right? The pelvic one is more like you have trauma, you have a force on one end, and then the force travels the entire ring to reach somewhere else. So similar in that it can affect the entire ring, the entire bone, but a bit different in that
The forces?
in the forces.
Because it says that it's a burst fracture of the atlas. So what kind of force causes a burst fracture?
You can, like diving, for example.
Mm,
You went
okay.
diving, you let in all that pressure there.
So a burst, so to kind of like talk about burst fractures are a bit different from like a transverse fracture in that a transverse fracture, right, it's kind of like it just breaks in half, right? You've just got your two pieces, right? A burst fracture is more like you've got this pressure that's coming in together from both sides, right? And it causes almost like an explosion, right? A burst. So that's where the name burst fracture comes from, right? So rather than this kind of like shearing force almost, right? Or this breaking force, it's coming from both sides that causes it to burst in the sides the pressure is not coming from. Does that make sense? Right, it's like if you have a water balloon, right, and you press this way, then the water balloon wants to expand out this way.
Separate one.
Okay, thank you.
Okay, and then the important anatomy that we'll be going over, we don't need to know about this ligament. The interior posterior arch, that's very important to decide what part of the body is. You need to know the atlas and the axis, and very important, you need to know the joints right here. The alento occipital joint. Can anyone tell me what's that connected to?
Atlas
Okay, and
and
the occipital bone. And what's that part? Is that part of your skull?
Yes,
Yeah,
it's the back.
Yeah, it's the back of it, exactly. That's the occipital bone. So yeah, anytime it talks about a joint, just try to put the two names together, and those are the bones that are usually connecting, right?
and two for interior Or it's like this is what
Atlanta for Atlas.
Where?
the whole name is what Atlanto.
Atlanto,
Is the whole name
like
is what?
the atlas, right? Atlanto, occipital, that's the occipital bone, and that's the joint right here. So you can kind of see this part, this is the bottom of the occipital bone right here. So atlas, occipital, and then you also have the lateral atlanto-occipital joint. But mostly the questions that he usually gives me, what is the joint that connects the atlas and occipital bone? And it'd be that atlas-occipital bone joint. Everybody has that? I'm going to the next slide. So yeah, cervical spine anatomy. Like I said, this is the what?
Cerebral.
Spinous
C-spine.
process.
Yeah, spinous process, right?
Spinous process.
And when you're always counting, it gets really small, and then the biggest one that the first one that protrudes backwards is the vertebral prominence, right? Like when we went over the x-rays, right? And so, same thing, C1, always first, C2 second. And on the side, we have these sides on the transverse. So, you can see right here, these are the transverse foramen. So foramens are like little holes. Like anytime we talk about like the obturator foramen, you know how they have the little holes in the pelvis, right? The same foramen, but it's on the side of the transverse. See? And then also very important, we had the lamina that connects the spinous process to the what? to the what's this called, Mr. Phung?
The lamina?
Yeah, lamina connects the spinous process to the
Facets.
Oh,
the facets.
so yeah, you've got your lateral masses with the facets above and below.
Below. Oh, yeah.
So they connect to the articular processes, and then those hold the facets.
Right. So the articular process is the facet,
Okay.
right? What do we mean by articular? Articulate.
To
To
the
something.
nerves and all comes
To
from the
connect
something
triangle.
loose.
Articulates and connects.
Yeah.
Right. So when things that articulate, they connect, right? Like our joint spaces, right? We always talk about articulations in our joint spaces. Two bones articulating at the joint. So our articular processes, right? That is where the upper and the lower spine will connect, where they will articulate. So that is also our facet.
But what was your question, Jalen?
For which one?
When you said the lamina connects to what?
So the lamina, this is the two important questions that we always get. So it's gonna say, what does the lamina connect, right? The lamina will connect to the spinous process to the superior articulate facet, correct?
So you have your lateral mass there, which has the superior articular and inferior articular facet, right?
So the lateral mass is what you're talking, or what he's asking about then.
So it will depend on which vertebrae you're dealing with, right? So you'll see when you get down to the T-spine, we won't really have a lateral mass anymore. It's just going to be like your facet, and then you're going to have your transverse process.
And then the organs, or
And you're not going to have your foramen anymore once you get down to your T-spine.
It all changes.
So yes, this is going to be very specific to C-spine. Now, as far as I go, I'm not going to go too far into detail here. The main reason I'm going to cover this anatomy is just so that when we talk about such and such being dislocated or being fractured, you have an idea of exactly what we're talking about. So I'm not going to go too far into detail. However, next semester, you will cover spine with Mr. Donahue. At that point, you will need to know every single one of these labels, right? So if you want to get ahead of the curve, you can start trying to take a look at these. But for the most part, main things to pay attention to are going to be your facets. Know that your facets are where your vertebrae will connect on the sides. Okay, pay attention to the vertebral bodies. Right? The vertebral body can get fractured or can get compressed as well. Pay attention to your different processes, your spinous process, your transverse process, and of course for the C-spine, the transverse foramina. And then also pay attention to the space in between the bodies. Do we have a label for in between the bodies there?
on the left.
No, okay.
So
We'll
those
wait
are
for one of the,
discs.
right, it's the discs. So we'll wait for one of the later slides then.
Herniated discs. Or,
HMP?
yeah, herniated discs.
So the thoracic spine anatomy. So with the thoracic spine anatomy, as you can see, what kind of curve is this right here?
Okay. Oh, this one is a convex on the opposite side of the.
That's a kyphosis.
Kyphosis, right? The interior side. So
Jill, I have a question.
Yes, ma'am.
Now, if you point on the other side, then would that be the convex side?
yeah, that's the convex side, right?
But then, how do you know which side are you referring to?
Because you would say the anterior or the posterior side to the body. Yeah, those are the main key parts. But with the thoracics, you just gotta know the lamina. It connects the spinous process with the transverse process. That's gonna be a Mr. Donahue question. I don't know if Mr. Phung will put that in the test. But for the most part, it's basically similar to the cervical spine. There's a couple of difference. As you can see, main things you want to focus on is the intervertebral foramen. It's a little space right here. And then we got the intervertebral disc right here. Spinous process coming posterior out. And does everybody know when he says superior and inferior articulation? Does everybody understand that process? So what articulation would this be? Right here.
T6 and
Because it's
T7.
what T6 be? Or this vertebral
Inferior.
to this one.
We have to be superior.
Superior,
Superior,
because it's on
yeah.
top. So it's just
Talking about the little facet.
yeah. So it's just superior is just basically on top, and then inferior is basically at the bottom. And then go ahead.
Did you just say lamina and that one connects the spinous process with the transverse process?
Yeah. So you see how the spinous, you have the lamina, and it goes to the transfer process.
So it's connecting both of them.
Yeah. So that's gonna be a test question. He's gonna say, what part connects the spinous process and the transverse process, and that would be the lamina.
And that connect the spinous.
Mm-hmm. The giraffe. That do look like a giraffe. Huh? Madagascar. Alright, and then also the pedicles. Does anyone know what the pedicles would look like on the X-ray? No, it'd just be like these little white circles on the
Like
on
the
vertebrae.
eyes?
Yeah, look, yeah, the eyes. And when you get to more vertebrae with Mr. Donahue, you guys are gonna talk about the Scotty dog. It looks like a dog when they're articulating and the inferior are articulating.
And when they oblique, you'll
Yeah,
see
when they
the-
oblique the patient.
you'll see the
exactly.
Scotty dog.
Mhm.
So did you say pedicles look like white dots?
Yeah, they look like little white dots.
like eyes.
Eyes, yeah, and that's how you know you're in a good oblique when you see those pedicles. Okay, and then this is very important. The two joints that you might need to know is the coastal transverse joint. So that's basically connecting the transverse to the rib. Right. So highlight that down right here. Coastal transverse joint is connecting the rib to the transverse process. And then another joint is it connects the body to the rib is the coastal vertebral joint. So as you can see, it's in the name, right? So coastal vertebral is connecting the rib to the vertebra, so the body. And then coastal transverse is connecting the transverse, right, to the rib. So those are the two that you need to know right there.
Coastal is synonymous with rib.
Mm-hmm.
It's costal.
Coastal.
Yes, coastal, right? That's for the sea, but costal is gonna be for the ribs. And you should actually be familiar with the root costal, because where have you seen costal before?
Costophrenic angles.
Costal phrenic angles. Very good. There you go. So costal are your ribs.
What you said costal vertebrae is connects to the ribs and the vertebrae. Okay.
And the vertebrae. Yeah, the body of the vertebrae.
Okay, thank you.
Coastal transverse joint is the costal and the transverse process.
Yeah, it's
No, what's the costal meaning
the rib,
rib and the transverse
the
process?
transverse. Yeah, it's in the name. You know, with the joints is
So
always
costal
in the name,
meaning
right?
ribs and transverse.
Transverse process, right? And the coastal vertebral is the connecting it to the body with the rib.
And those, I'm sorry.
Go ahead.
Those are diarthrotic because they like they
They're
move a little
slightly
bit.
movable. They're not freely movable, and then they're not. You can't move them. So they're that.
Amphiarthrotic is, or I
What
thought
are
that
those
one was
considered?
like
That
fused.
I'm not actually sure.
This-
I
I
don't
know
know.
there's
synovial
like-
is synovial, right?
Synovial is freely movable.
Yeah, so synovial.
Synovial is the capsule.
So
And that
diarthritic
one
is
is freely
freely
movable, but
So then amphiarthritic.
Is
no
Okay.
capsule. Right, sir?
That I do not remember. That is Mr. Donahue's specialty.
What, Mr. Phung?
Yeah.
It's been a while, okay? Give me a bit of leeway here. All right, but let's try and move on to the lumbar here.
Okay, so we have the lumbar right here. So how many lumbars do we have again? Five. Yeah, and these lumbars, they have the same thing. They have the inferior and the superior articulating process. And then with the vertebrae, yeah, same process. The facets that we need to know, the spinous process. The nerves, you really don't need need to know the nerves in this chapter. When you get to Mr. Donahue's class, that's when you're gonna need it. And then we have the lumbar sacral joint, and it's in the name again. What is that connecting?
Lumbar and
Sacrum.
Lumbar and sacral, right? It's in always when the joints is usually in the name. And then very key factor right here, we have the SI joints right here. Right? So SI joints connect the sacrum and the pelvis together. Everybody got this?
And what pathology did we look at last chapter that involved the SI joints? So that's right, ankylosing spondylitis, right? Fusion of the SI joints and also the spine.
yes, the joints connect the pelvis center.
Pelvis and the sacrum.
And then spondylolysis is the seatbelt injury.
We'll get to there. We'll get to that.
So our first pathology that we have for today is the unilateral subluxation and / dislocation. So basically, this is where the zygopopliteal joints can be disrupted or trauma. As you can see in this image, this is a perfectly normal spine, right? But as you can see, you see how the facets kind of shift on top of each other? That's where the dislocation occurs, right? And this is where the dislocation occurs as well. So it can come from flexion, distraction, and or rotation that then only one zygopopliteal joint may be out of alignment. So that's why it says unilateral. So unilateral is referring to one side of the vertebrae. As you can see right here, it's just one side. You see how this side is perfectly on top of each other? And on the other side, that's where it shifts. So key word, unilateral. And it can also be called a bow tie sign, right?
So which way did the superior vertebrae dislocate? Did the superior vertebrae move anterior or posterior?
Anterior.
The top one moved, well, the
Keep
top
it
one
sensitive.
moved anterior, right?
Anterior.
The
Yeah.
bottom one
Was
went
posterior.
posterior, right?
Or did it stay there? We can't see in the picture.
You can see the
can't see
picture.
it.
But it has moved, the bottom one has moved.
Right,
Like
so
we just
we're
see
looking
one-
at the top.
So if you're looking at the top one, it has moved forwards
Yes.
in relation to the bottom one, right? If you're looking at the bottom one, it's gone backwards in relation to the top
I was
one.
looking at it a different way.
So the unilateral is like only one section dislocates.
Correct,
One
so
section.
only one side.
You see how that one section right here is dislocated?
So the unilateral one is going to be called the bow tie sign. If it was a bilateral one, it would be called something else.
So no, the bow tie sign is what we would see on the actual radiograph.
Okay.
So bow tie sign is not another name for this. Bow tie sign is how you would see it on your X-ray. Remember how we had like our bird beak sign and our coffee bean sign, right? Same idea. When we see the X-ray, you'll see that it looks like a bow tie almost.
Okay.
So that's why they call it bow tie sign.
So what would the other name for this be?
Just unilateral subluxation if it's a partial dislocation, or unilateral dislocation if it's gone all the way.
Okay.
So let's take a look at some actual images.
Thank you.
You're welcome. So, do you see it there on the left image?
Jalen, could you point it out?
But you guys pointed out.
No.
Oh, yeah.
Want to switch the lights?
Yeah, just dim the lights. Dim the lights.
Oh,
Oh, that's better. Thank you.
Now do you see it?
So you
Like
gotta
the
look
6
for
or
the
7?
Yeah.
6 or 7?
You can keep going.
Maybe,
Stop
yeah,
right there.
like
Right
that.
there?
Yeah.
This is what you think it is?
Yes, sir.
Yeah, I'm like 6, 7-ish.
How is it different from the one on the top?
5,
You could-
6,
A little bit further, guys. A little bit
I don't
further.
think so.
right
this
over
could be
here.
one,
Right,
two,
so do you see
three,
how
four,
everything
five,
looks like it's on
six,
top of each
seven.
other up until here? You all see this is
Oh.
more interior and this one's more
Posterior.
posterior?
It's like a big open gap right here.
So 1, 2, 3, 4, 5, 6. So 6, 7-ish.
Mm-hmm. That's right. And then if you look at the right image, right, same thing, right? You can see the body, and this body is kind of shifted forwards compared to this one right here. Now this one is not a full movement interiorly, right? This has only gone partially forwards.
And what's that called?
Subsection.
Subluxation, great. But then you see how this forms almost, they say it forms like a bow tie looking thing here.
So
Right.
the bottom portion is moved up, is that what you're saying, sir?
So this has moved forwards. This, yes, this has moved up because this facet is trying to pop itself onto the other side. If it does make its way all the way over, that becomes the full dislocation. Right now it's just a subluxation.
So
It's
we're
starting
looking
to
at
slide off here.
So we're looking at that little pocket between the vertebrae.
So this here is one facet.
Mm-hmm.
This here is your second facet. The facets are supposed to be sitting on top of each other like this.
Right.
It's slid up like this. This is your subluxation. Still partially touching, right? But it's almost gone all the way over like
Right.
this. Right, at this point, that would be your full dislocation. So right now you're looking at this facet versus this facet here.
Facet
That's
means two
your goal.
vertebrae, different vertebrae?
Facet is where your vertebrae are supposed to touch. So the top vertebrae has the inferior facet, bottom vertebrae has the superior facet.
So then on the left image, it's right under the vertebral prominence, like directly under it,
1, 2, 3, 4, 5, 6, 7.
or
So between 6 and
6,
7.
7, or C7.
C6, C7.
Facet is when the vertebrae meets.
Yes.
So the next one, this is called a bilateral lock. So bilateral means both, right? Unilateral means one. So bilateral lock. So with this one is the same concept as the first one, but with this one is both sides of the spine shifting, right? Not just one. So zygohypophyseal joints can be disrupted by trauma. If it comes from extreme flexion or distraction, both joints can be disrupted, which creates bilateral lock facets. So as you can see, this is a really good image. You can see how both of the facets, both of them are both dislocated, correct? Can everybody see how it's dislocated? On both sides? Same right here?
Which is without location, with dislocations.
This one's normal. And you
But
see-
that's a different view, right?
Yeah, which one?
No, it's still the same level.
So this
It's
is
a side
lateral,
view.
and this is another lateral image, right?
Oh,
You
this
see
is a
how
good-
both of them are shifted forward, not just one side? Both of them completely came off the faucets, right? Same thing right here, completely off, right?
Thank you.
By the way, this bottom one, what view is this?
This is the AP views.
AP.
No,
No,
it's
it's
no
a
side, the lateral views.
It's a PA.
Isn't it
It's from the side.
The bottom one is PA. How do you know it's PA?
Spinous process.
Right, you can see the spinous process.
Always look at the spinous process. That it tells you everything that you need to know when it comes to how the body is obligated, orientated. So spine becomes unstable and places spinal cord in danger. So as you can tell, you don't want, if you see a spine like this, you know it's very not unstable. Okay, so be very cautious with this. You know, when dealing with a patient like this. So everybody understands the difference between the first one, the unilateral, and the bilateral, right? So how many sides is dislocated on the unilateral?
One.
One side, and then for bi, bi, yeah, and it's in the name. So right, that's another hint. All right, we're going to the next one.
Hold on 1 minute.
Oh, hold on. My apologies.
It's okay.
How does this happen?
How does this happen?
Extreme flexion.
Accidents. Accidents can cause it, right? So, you know, has anyone been to shock room? In their rotations? Shock room. Yes? No?
As a
Yes?
patient,
As a patient, hopefully not. Okay? And so, when you go to shock room and you see your patient, right, they could be there for any number of reasons. Have you seen any car accident patients go to shock room? MVAs, MVCs. Yeah. What do they have on their neck?
C-collar.
C-collar. Why do they have that?
So that the neck is
All right. Trauma.
Because you're afraid the spine might be unstable. Why might the spine be unstable?
Because of this.
Because something like this may have happened. Right?
We had to go to a patient's room yesterday and he had one on to do a cervical.
Mm-hmm.
And I'm like, the doctor gonna put the swimmers? He put the swimmers on
Put the
order too.
swimmers?
But the guy couldn't raise his arm.
Yep,
Took
that's
that off, or was it just hard?
No, he really couldn't move his arm up, but we had to like build to set up for the lateral. So that's crazy.
Yep. Yeah, that's something you'll learn. Doctors will order any kind of X-ray they want without really caring about whether or
Yeah.
not the patient can actually carry it out. So that's your job as a tech.
So
Yes, Nancy.
Difference between that unilateral and bilateral. So we're just looking at two vertebral. What's it called?
The superior and inferior articulations of the fossils.
Yeah. So for unilateral, so one of them is anterior, one of them is posterior.
That's what I wanna know.
And then for the bilateral, both of them go up
Yeah.
front or both of them go
Yeah,
back.
Yeah,
both, it can
because
either go front or
bilateral.
both. It's just,
Okay.
which,
Yeah.
Okay, so it is always going to go, the top portion is always going to be in front of the bottom portion.
Always?
So it's all just about how we choose to describe it, right? If you're looking at the top is now anterior compared to the bottom. If you're looking at the bottom looks posterior compared to the top. But since the body is primarily down here, right? We'll say that the top part has gone anterior. So it's an anterior dislocation.
Thank you.
Does that make sense?
Yes.
Right, because it's the head and the top part of the neck that's going forwards. The rest of the body is now going to be in the back compared to them. Does that make sense?
Yes. Perfect.
Right?
You sent us this PowerPoint on Wednesday, right?
I did, yes.
Because I was confused.
So it all just depends on which one you're looking at. But you're never going to see the top part go backwards,
Okay.
right? Because if you just think about it, right? You think about how these facets work, right? You've got a facet and a facet. They look like this. They go like that. You're going to come back, right? No problem there, right? But sliding this way and then getting caught, going all the way past and getting caught like this, so it can't come back. That's where your big problem is going to be. So it's going to be this anterior dislocation, right? So these are primarily anterior dislocations. The top part is popping off and coming in front of the bottom part.
So it's bilateral two.
Both sides
Both
are
sides.
popping over.
Anterior side.
it's
Which
the
means-
sides, the sides right here. You
Right.
get two faucets on one side, so one side right here and the other side. So it's bilateral, this side would just shift, but this
Actually,
would be normal.
Jalen, do we have those vertebrae models?
Yeah, it's in the room. It's at the bottom, I'm pretty sure.
You never see the facet move back, or you say you never see the vertebral back?
Have I seen it?
No, which would be the correct way to say it? You never see the, and Mr. Phung was saying, you never see the facet move backwards, and you never see the vertebral move
Vertebrae.
backwards.
Vertebrae moves in front.
It's not a facet move.
Dude,
The faucet's just the space. It's the vertebrae that gets stuck.
if I didn't finish like that or start the movie like I did, I would start to feel sick. Like dizzy and shit.
So can anyone see the fracture? The
Yes.
bilateral lock right here?
Yes. Number 7.
It's right here, guys, right? So whenever you guys find a specific region, right, you always want to put the number of you want to put the anterior number and the inferior number. So for example, you see how this location is right here, right? So and this is C7, right?
Yes.
C6. So you said the bilateral lock is within C6 and C7. So that's very important to how to arrange those numbers, right? Start with the top one and then the bottom one. And then this right here, this is just a regular MRI right here, or it could be CT. I'm not quite sure. It could be one or the other. Most likely CT. But you can see how it's dislocated right here. But do you still understand what I mean by both sides, the bilateral and the unilateral?
So both sides like this.
Yeah, yeah, both. That's a small one.
Well, yeah, they're C-spines. They're going to be small. All right, so if you guys want to see this, come up front here, or at least come here to the middle so you can see this. Right, because This is kind of small, right?
We don't side shame.
Right, but cervical vertebrae. How do I know that these are cervical vertebrae?
You got the dams and
No dens.
I mean, not the dams,
The
the
spinous.
the spinous processes.
What do we have on the
Apertures,
sides?
Foramens.
The transfers.
That's right. We have transverse foramen, right? Only exists in the C-spine.
Test question.
That's question. Yes. So put them on top of each other. Do you see where they meet up together? Right here. These two sides. You see where they meet? See how they go on top of each other right here? Right? So we've got our left and our right facets. Right? Left and right facets. Okay. So front, right? Front, side, back. Right? Back has the spinous process. Great. So let's take a look at this from the side. You see how these are articulating with each other right there? Now imagine that there's an accident and this goes
Boom. What's that called?
The bias.
so you see how this has gone anterior to the bottom one, right?
It's unilateral.
Right? But it's only on one side. It's only on one side.
So it's unilateral.
Unilateral, great. Right? This facet, only this facet pops forward. So that's our unilateral. Now, if both facets pop forward, like this, now what is that?
What's that called?
Bilateral.
Great, that's our bilateral, right? If we take a look from the top here, right? See this here? This hole in the middle? Guess what goes through that hole? Right, spinal cord. Now, we have unilateral dislocation. Okay, so still have a space through here?
But narrow probably.
A bit narrower, but still okay, right? But now imagine both sides pop forwards. Is anything holding this now, right? Just floating around now, right? Not being held in place anymore. So imagine that this goes on the spinal cord. What happens?
Pinches, of course. And then
Paralyzation. Yes. So that's why bilateral dislocation of those facets are very, very dangerous. So do be very careful with patients that are on C-spine precautions, right? You don't want to accidentally paralyze them for life. But as far as anterior and posterior goes, right? Whichever one's on top is going to be the one popping anterior, right? Pop those anterior.
That's why we always take off the C colors.
Oh, sure. I'll pass these around. Just make sure you give them back to me at the end of class.
Johns.
You said on the bilateral, Mr. Phung, you said on the bilateral one, the top one is always anterior?
So
Or is it on both?
both of
Unilateral?
them,
Okay.
uni and bi, it's going forwards.
All right, thank you.
The facet is 1 or 2.
Correct.
And one is not so dangerous. The two one bi is the one
Right.
dangerous one.
So
It's gonna
one is
cause-
one is bad, but two is very bad.
They're both bad.
Mhm.
So the fractures that we'll be going over today, we already went over this with the worksheet that we did. So with the Clay-Shoulders fracture, Chance fracture, compression fracture, hangman fracture, Jefferson fracture, Doington fracture, and the teardrop burst fracture. So these should sound all familiar with you guys, okay? So the Clay-Shoulder fracture, the most preferred view is the lateral view to see what happens to the spine. And this is basically an avulsion fracture of the spinous process from C6 to C7, right? It results from hyperflexion of the neck. And does anyone know what an avulsion fracture is? Yeah. So yeah, the ligament pulls off a piece of the bone, right? So as you can see, it's in the most current spot. It says C6 and C6 and T1, right? Keep that in mind. And as you can see, this is how it.
Do you see the spinous process? Look at the spinous process.
Oh, yeah, right there.
Right there, right? You see that fracture right here? Exactly.
So what do we mean by hyperflexion? No, that's extension.
Oh.
Flexion, yes.
Flexions going forward, extensions going
Like
back.
reduction of angle.
We were already in extension, so this is hyper.
Hyper.
Yeah, that hurt when I did this one.
Pass it around that way.
I'm good.
Go on to the next. So the transfraction, you know how I said the transfraction for the C, right? So this is from a seatbelt fracture. So whenever people are going 100 miles, right, they crash, they're automatically gonna do what to their body? Where's their body? Hyperflexion, right? Causing that C. That's why I like to say C, the seatbelt, right? And this is a sudden cause of a hyperflexion force. So a car crash, for example, correct? And this is fractured in the spinous process, the pedicles, the faucets, and the transverse process. So as you can see, yep. As you can see,
Ooh, yeah, that looked like it
Well,
hurt.
those are fractures.
yeah, right. This is on the MRI, correct?
Oh, this is a CT.
CT, okay. This is on the CT.
Right. Right, so, right, this is what a healthy body looks like, right? Healthy spinous process. And then over here, right, this fractured here, this fractured there. We've got a fracture up top here. So, yeah.
Just a
Do
little
they
bit
do
of yoga.
surgery? I would assume so, yes.
They could walk out.
Yeah, they probably do some sort of spinal fusion for that.
It'll be fine. Just walk it off.
By the way, spinal fusion, if you ever do OR and you see a spinal fusion case, I guess, I know I've been taught with Dr. Kong, those used to take like 6 hours at minimum. So those were fun.
Spinous procedures take a very long time. So everybody understands how it occurs and what it affects, correct? On to the next. So,
Yeah, so some other examples or images of the transfracture. So do we see the fractured transverse processes or the fracture to the body over here on the left side?
Yes.
Yeah. It is slightly under the center.
So you see this dark line right there?
that's right in between the vertebrae.
Do they also have damage to their disc?
So that you would need to check the disc space. You can't really see the discs on an X-ray directly, right? Discs are cartilage, soft tissue. So for discs, you would want to use an MRI, right? But you could look at the space here and see if the space has changed under weight. Right? But at least as far as the bone goes, right? You take a look at this. You see how there's that fracture right there? See how it like chipped off this corner of
Yes, sir.
the bone right there? Yeah.
You said that this picture they're underweight, like they're,
No.
they're weight bearing right now.
So-
'Cause it looks like they're on a backboard.
So if you want to see disc spaces, you need to have them weight bearing.
Oh,
is what I
okay.
meant. Sorry. So yes, this is not weight bearing. This is definitely supine. But if you want to see disc spaces, the patient has to be weight bearing, and then you check the distances between the vertebrae. If you want to see the discs directly, you have to use MRI. You cannot use X-ray. Liking MRI?
It's really chill.
It's really complicated.
You can. It's just
Lots of physics.
lots of physics.
Lots
yes.
of physics.
So this one, as you can see, fracture to the vertebra, to the body.
They centered really well.
And right here. So can you guess what this thing is back here?
That's the spinous process.
Spinous process. Good. Fracture to the spinous process.
Do they have all? Do they also have fractures to the vertebral bodies?
Mm-hmm.
I think I see two.
Yes.
See right here, this one right here.
Mm-hmm.
And you can see it right here. You see how it's a line cut right there? Hey, can anyone tell me why the spinous process, you can see it right here, but you don't see it right here? This is more of like MRI or CT question. But
One more time?
so this is an MRI or CT.
That's-
Why can you see the spinous process, but why can't you see this one? You can see this one, but you can't see that one.
It's been affected.
Anyone got a guess? So you know when we do CT or MRI, there's a bunch of slices, right? So it's just slices within the body. So at that particular point of this slice, this one's just really visible, and then this one's just a little bit more deeper within the body. So yeah, that's about
Oh, because it's like
It's sliced, right?
I see.
It's sliced by
Yeah.
pictures.
That's right. And you guys will be talking about sectional imaging at the end of this course, right? Because this isn't just pathology, this is pathology with an introduction to cross-sectional anatomy. Very good. So remember stuff like this.
So we're gonna be able to start looking at like MRIs and CTs and understand.
Mhm.
At least
Okay.
understand the anatomy or how you're looking at it.
MRI is cross-sectional imaging,
Yes.
Same thing with CT.
CT also.
Yeah. So compression fracture is the next fracture. It's explanatory. Compression, right? So the main part is the vertebral body is getting compressed, right? And so this deals with the vertebrae. Vertebrae body is compressed or collapsed. Can be seen on X-ray or reduced height in the vertebrae body, right? So you can see how it's squished right here. And these can happen from people diving a lot of times. You know, when they say don't dive in the pool, it's exactly what they mean. Don't dive. This can be a possibility. And as you can see, the vertebrae is completely flattened right here. That must have been like a tall diving board, huh? Well, yeah, that's exactly what happens.
Shallow pool.
And then this compression fracture, it can happen to C-spine, T-spine, L-spine even, just depending on how you land and just the way you land. And the best way you can see this is lateral and AP, and then you can use CT or MRI.
So did you say it happens to C-spine?
Bless you.
Bless you.
And
Yeah, it can happen anywhere within the spine.
I think we have some other pictures of other spines. So which spine is this right now?
Which side? A lateral?
C-spine, good.
Yeah.
Do we have any others? Or just that CT? Alright.
So this is another CT one right here. It kind of looks like a burst fracture. You know how you said when you squeeze it right, it kind of goes to the opposite ways. So it looks squished and kind of fractures out the way. And this was also a compression fracture right here. You see the length of this, the length, and it's just half of that, right? That's another indication that it's got compressed. We have the next fracture we have is a hangman fracture, right? What we say about the hangman fracture? How do we call this?
yourself.
Oh, you hang yourself.
Oh, right.
Yeah.
You hang yourself, right? And
When
it's
you
like
hang yourself.
Yeah,
That's what you said.
When you kill yourself.
It was just
Oh, no,
it was just
no.
his facial expression when you said hang yourself, and Mr. Phung looked at you like, you know, so.
the second vertebrae.
Yeah, the second vertebrae. So
Okay,
key,
so
highlight
what
this
did you
one.
teach y'all?
For the hangman fracture, it occurs at C2, okay? And the way you can think of it, like hangman, they have a rope around the neck, and it's just C2, right? Deals with the cervical spine. This is usually deal with the cervical spine. You won't see the hangman fracture any other, like in the thoracic or the lumbar. And they can also fracture the pedicles and the pars
Articularis.
articularis, right? So in the image right here, you can see there's a fracture right here, and the pedicles kind of, well, that could be, but the fracture's right here, the hangman.
On both sides?
Both sides, correct?
Yes, and this one is just on both sides, yes. So, right, right back in the old days when people would execute people by hanging them, right? What killed the people? It wasn't them choking to death, no, it was
Force.
right, snapping the neck like that, right? So hangman fracture.
Hangman fracture. So very lethal if you ever encountered this.
So to say that if the spine breaks, then
Like
you
an
die.
X-ray, you mind get that
You might
X-ray shot?
As a tech, yeah.
As a tech.
Hopefully we don't.
Oh, Ben Taub, everything's a miracle with that.
Do you have any other pictures of that?
So you can see. So which one's the first one? What's the first one called? Atlas, right? Atlas. And we got the axis, right? And you can kind of see on the side right here. It's not that visible, but there's a big separation right here. You can see it? You guys see the TV.
Yeah, the TVs are a bit better
Is it
here.
axis
Yeah.
or axis?
It's a fracture of the axis.
And then with this one, will it be a combination of bilateral? with the hangman too as well, or
Oh, with like the facets.
yeah, with the facets too.
So with the facets, we're talking purely about dislocation.
Dislocation.
If we're talking about fracture, then
It'll be hangman.
hangman fracture.
I just
But-
want to clear that for you guys.
So it could be a combination of both then. Like they have the dislocation in addition
I
to the
mean,
fracture.
I suppose it's possible, but in this case, it's not. The body only looks like it's forward because there's nothing holding it back, right? Because you've literally broken the pedicle, so now the body slides forward. It's not that the facet has moved over here.
So it's
in
taking
this
the
situation.
second one or the third one with it as well.
So in the hangman fracture, right, we don't have a facet dislocation. We've got facet here, we've got facet here. They're still in the correct spots. But the body looks like it's more forwards. Why? Because the pedicle has been broken,
There's no lock.
right? So the pedicle is what holds the body to the facet, right? Without the pedicle, then the body can move independent of the facets. The facets can stay still, but the body can move forwards.
Alright, Jefferson fracture, my favorite, right? So Jefferson fracture, it's a community. What happened? Comminuted fracture of the interior and posterior arch of C1. So a key part about Jefferson fracture is in C1, alright? And then you can see how it's the anterior arch. Is this the anterior or posterior arch, guys?
Posterior.
Why? Why is that?
Because the spine is
Process, right? Spinous process. So you have this posterior arch right here and the anterior arch, and those are both being fractured. And this is caused by axial loading. So it can be landing on the head or feet after a fall, right? And feet after a fall, this might look weird, but that energy can all like travel from your feet all the way to your spine.
That's why they want you to bend your knees when you fall.
Yeah.
That's not good.
I mean,
No,
it's
that's
gonna
how you
hurt
do
either
it.
way, so, I don't know.
So you bend your knees and roll.
Are there
Then
two
your
fractures on the
foot was just-
anterior?
You bend your knees and roll.
Your
Are there two
tibia
fractures on
yes,
the
pop out.
anterior?
No.
Fracture.
No,
I've
those are
done
the
second
two
story
on
building.
both of the anterior.
And you just bend your knees and roll. Let it take you. Don't fight it.
Yes, this is an avulsion fracture as well.
Also anterior, sir?
Yes, that's anterior.
Oh, that's a ligament.
If you were to drop this eraser,
So it's a
it
ligament.
naturally bounces and continues forward. Right? That's what we're supposed to do. Minimize the energy transfer. What's up?
I'll never get these two.
So yeah, Jefferson fracture, right? Anterior, posterior, right? Fractures of anterior and posterior arches. Okay. Over here, let's see. So we see this sticking out here,
What is that called?
the thing sticking up.
What's this?
Oh, then, is that Dontoid?
Great, right? So this is C2, right? Not
Yes.
looking at C2. We're looking at
C1.
C1 up top here. Do you see the fracture in C1? Over there on the side, on the left side. Do you see the fracture there?
I think so.
Yeah.
So, good, fracture, fracture, great. Okay, so that's C1,
Which one is C1?
C1
the one
is
on the top. Okay, how many, is that it?
It's easier to see on the TV.
Alright, yeah, we'll have to stop here. Alright, so,